Akana?
Thank you, Mike. I'd also like to thank National Council and Cochs for hosting this really important conversation about the intersect of behavioral health and criminal justice and the important role of the Excellence Act and 223. SAMHSA is a really proud partner with CMS and ASBE as we work to implement Section 223. And at the heart of that are the certified community behavioral health centers, which we're excited to see coming to fruition. Just as a little bit of context, as Judy, Linda, and Dan have demonstrated and described, the gaps in the physical health and behavioral health services really come to a head when you're intersecting with the criminal justice system, as I think Mike outlined for us. And we know the mental illness is high, substance use disorders is high, and trauma is nearly ubiquitous for folks in these systems. And we have a dynamic patient flow between criminal and juvenile justice and behavioral health. Unfortunately, we're sending people to them, and they're sending people to us. And recently, we had a treatment episode data set study that came out looking at data from 2003 to 2013, and on the substance use disorder side, at least 34% of the referrals that our public substance use treatment providers are seeing are coming from criminal justice systems, parole, law enforcement, drug courts, et cetera. So we're really need to be hand in glove with the CJ systems as we move forward. And that's why SAMHSA has a trauma and justice initiative where we've prioritized these issues, looking at critical behavioral health issues for justice-involved individuals, improving access to treatment and recovery, reducing encounters with law enforcement that lead to arrest, and fostering positive reentry into the community. And we're responding so that as a nation we can work towards reducing the justice involvement. And we are investing every year $100 million in services and programs to advance these issues. So some examples in Knoxville, Tennessee, and Boulder, Colorado, in our Law Enforcement Behavioral Health Partnership for Early Diversion grant program, we've helped communities implement effective and collaborative strategies for pre-arrest diversion, including crisis intervention team training, sequential intercept mapping for the community, and assessment and resource centers for warm handoffs that we know are so incredibly important to engage people. And we're also proud to support the administration's efforts and focus on reentry. We're active in making grants to states and communities on facilitating the vital services, including comprehensive mental and substance use disorder treatment, case management, wraparound, medication-assisted treatment for people who are re-entering their communities from the criminal justice system. And finally, a very big piece of our portfolio is our treatment court program. And so in 2014, over 7,000 clients received services through SAMHSA's treatment drug courts and our tribal healing to wellness courts. So we're fostering that culturally appropriate services, particularly in tribal communities, which you've noted have such a high prevalence of these issues. And we also have a relatively new initiative of our Behavioral Health Treatment Court Collaborative, which is modeled after some real innovations that we've seen in places like Florida and Texas to allow more flexibility and innovation between local courts and their criminal justice and behavioral health partners as we work to go beyond the four walls, I think we've talked about, in creating these virtual systems of care. And so as we are trying to make investments here and enhance our focus on CJ issues, a necessary piece of the puzzle is work to increase access to quality community-based behavioral health services. And so the Certified Clinical Behavioral Health Center criteria, the planning grants, and the 223 demonstration program are going to be fabulous starting points for us to bring high-quality, expanded behavioral health care into communities where services can be accessed and coordinated to better meet the needs of CJ-involved people with behavioral health problems. So originally, I think, as I'm sure Senator Stabenow shared, and he's heard from Linda and others, the Certified Community Behavioral Health Centers were envisioned as comprehensive behavioral health care, so serving adults and children with mental, substance use disorders, and co-occurring disorders in the community and integrating services with other community agencies. And so that's where this intersection in this conversation is so important. So the CCBHCs, which you've heard, are funded through the prospective payment system, so it's an enhanced rate of reimbursement by Medicaid. Oops, sorry. And the criteria that were used were developed by SAMHSA. CMS developed the PPS guidance, and ASBE has provided policy leadership as well as is doing the evaluation for the demonstration program. In the criteria that SAMHSA developed, we've emphasized high quality and evidence-based practices with the populations, adults and kids, SMI, serious emotional disturbance, and substance use disorder, as well as co-occurring, obviously. And we're trying to raise the bar on the quality, the access, the coordination, and the accountability, very important, of the behavioral services that are offered. So as we were coming up with the criteria, this was really a very exciting process, and some of our staff here, they can attest to it. You know, there are obviously different takes on how we could create the ideal CCBHC. And so SAMHSA engaged in some listening sessions and some dialogues on what stakeholders wanted to see, and there are different camps, but we heard from consumers, from providers, administrators, families, advocacy organizations, states and communities about what their ideal CBHC would look like. And if we didn't have enough fun the first time around, we worked very hard on developing draft criteria where we still saw the potential for a great deal of push and pull. So even though time was very short and we were trying to be responsive to our congressional partners and our administration partners in getting this out the door, we went back out for a second set of comment and put the draft criteria out in an effort to be transparent and open in the process so that people could see the things that we were struggling with and the balance we're trying to achieve. And so I think we came to a very good place and have come up with criteria that really represent a robust, accessible, comprehensive, effective mental health treatment, mental health provider, and substance abuse provider type. And as the sequential intercept model would tell us that this is best clinical practice is the ultimate intercept to keep people with behavioral health problems from becoming involved in the justice system in the first place. So the CCBHC criteria were developed to improve collaboration with community agencies, so that includes law enforcement as well as housing, social services, education, and employment, as well as physical health care. The criteria were also developed to improve crisis response. As we've seen in the news in recent months and years, when individuals are experiencing emotional crisis or in distress, it can be a problem for the whole community. And historically, as much as 10% of police contacts have involved people with mental illnesses or substance use disorders, and a disproportionate amount of these encounters do result in arrest. And so CCBHCs are required to provide crisis management services 24 hours a day, delivered within 3 hours, and must partner with emergency departments and as well as, and very importantly, ensure post-crisis planning and coordination to prevent further future crises and to assist in de-escalation. CCBHCs were also required to provide ongoing services that support people as they remain in the community. So the targeted case management portion of the statute required us to include the provision of targeted case management either directly through the CCBHC or provided through or referred through formal partnerships with other providers. And the purpose of that is to assist individuals, and we know our justice-involved populations are really in need of help to sustain recovery, gain access to needed medical, social, legal, educational, and other services and supports. So all this said, with the CCBHCs really at the heart of the Excellence Act, when fully implemented, this will infuse over $1 billion into the behavioral health system. So this is the biggest federal investment in mental health and addiction services in generations. And we are so excited that the future is within our grasp. We are dedicated and committed partners in this process, and with billing rates that will finally cover the cost of doing business, and that being acknowledged and recognized, providers' voices have been heard, consumers' voices have been heard, and we're excited to be playing because we think this is a game changer.
Thank you, Conlon.